I want to introduce our panelists so that we can have a chance to really learn a little bit more. We have Dr. Rebecca Dunsmore Sue. And in 2013, Dr. Dunsmore Sue started to build her menopause focused practice. And in 2019, she transitioned to her gynecology and menopause care full time. She founded the Women's Wellness and Gyne Specialist Clinic at Swedish Medical Center, where she was the medical director of menopause services to 2023. She joined Genev.com as the director of health to help build it into the premier online clinic for women in midlife and menopause and became their chief medical officer. She serves as the medical director at Seattle Clinic Research Center for Primary Investigations and Research. She also was an editor for Obstetrics and Gynecology from 2016 to 2020. She is a Menopause Society certified menopause practitioner and a fellow of the American College of Gynecology. Her current focus is on her practice and providing holistic, evidence-based care for women in midlife and menopause. We also have joining us Dr. Maria Uloko. Dr. Uloko is a board-certified urologist specializing in comprehensive sexual health reconstruction and prosthetics. She is one of only 7 urologists worldwide skilled in managing sexual dysfunction across all genders, offering expertise in treating vulvar sexual dysfunction, sexual pain, low libido, improving her patients' quality of life through a compassionate, inclusive, and shame-free approach to sexual health, empowering them to take control of their well-being. We also have Lisa Blunt Rochester, who's a congressman of Delaware. Congresswoman Lisa Blunt Rochester represents Delaware in the U.S. House of Representatives and serves as an assistant whip for House leadership. Lisa sits on House Committee for Energy and Commerce. The committee has a broad jurisdiction over healthcare, the environment, commerce, trade, energy policy, telecommunications, manufacturing, and consumer protection. Congresswoman Blunt Rochester is a leading voice in Congress on economic and future of work-related issues. As a former Secretary of Labor and State Personnel Director, Lisa leverages her professional experiences to advocate for legislation that boosts startup businesses, their growth, and removes barriers for citizens re-entering society. She is a co-chair of the New Democrat Coalition's Future of World Task Force. She's also the founder of the Congressional Future of Work Caucus. So with that, you can also see more details about our panelists and their bios on our website if you choose to do that. Congresswoman Blunt Rochester couldn't join us today, but she has a video that she taped for us. So let's cue that up.
Thank you, Denise, for that wonderful introduction, and good evening, everyone. And thanks to the National Women's Health Network for your leadership, vision, and advocacy for women's health. I'm so grateful to be a part of kicking off this incredible panel and for this film, The M Factor. Together, we are all a part of what I call the menopause movement. Over 20 years ago, there was groundbreaking focus and research on menopause. But since then, it's like this issue has been on pause. But today is a new day. In this moment, we're going to use every vehicle we can to make sure we have the resources and the support to care for ourselves and women to come. We're going to make sure that our doctors and caregivers are educated, and that we respect and uplift this incredibly powerful phase in our lives to, quote, pull back the curtain on menopause. For my part, I am a champion on legislation with my colleagues in the House and the Senate. I've introduced the bipartisan We're Addressing the Realities of Menopause, or the WARM Act, to create a national menopause public awareness campaign. And most recently, my colleagues and I have introduced a comprehensive bill called the Advancing Menopause Care and Midlife Women's Health Act in both the House and the Senate. Our bill would strengthen and expand federal research, it would fund awareness efforts, and promote relevant training for our healthcare workers. These bills are supported by Democrats, Republicans, and independents. And with all of your help, we're going to get these bills done. Tonight, you're going to hear the statistics and the advances that we've made, but you're also going to hear how far we still need to go. And I am so proud to be with you on this journey as we share our truths, advocate for our most basic healthcare freedoms, break the stigma, and love our bodies at every age. Now let the menopause movement begin.
So let's just start this panel discussion with Dr. Dunsmore Sue and Dr. Loco. I'm going to start with Dr. Dunsmore Sue. Thank you for joining us this evening. So we heard a lot about HRT, and we know that there's a lot of controversy around HRT. So what are the risks and benefits of HRT, and how can women make informed decisions about whether it's right for them?
Thanks for asking that. You know, in my practice, this is a 30-minute discussion with each woman because it's complicated. And, you know, we have years and years of data. And I go back to data that happened before the Women's Health Initiative that was talked about in the movie. I talk about the Women's Health Initiative and what it actually told us as opposed to what was put out there in the media. And I talk about the research that we've done since. And what it really boils down to, as Dr. Fobian said in the movie, is that for most healthy women who are thinking about starting hormones at the transition to menopause or in late perimenopause, early menopause, the risks do not outweigh the benefits of hormones. So we tend to think system by system. And what we can say based on research and data is that hormone therapy, specifically estrogen, supports your bone health. And it supports it for as long as you take that hormone therapy. We know that it relieves symptoms, whether they be hot flashes, night sweats, things like that. It relieves a lot of other symptoms too, but we don't have formal studies or formal FDA approval for using it for joint pain or brain fog or those things, although it will help with those. The data around cardiovascular health is a little more mixed, and it's a little more complicated to explain. We do have early data from before the Women's Health Initiative was even started, and the reason the Women's Health Initiative was started, we look at early observational trials. Women who started hormones at the transition to menopause and continued on them had lower rates of heart disease and stroke. In the Women's Health Initiative, it was the opposite for a lot of the reasons explained in the movie. And since then, we've sort of changed our prescribing patterns. We now use much more estradiol than we use conjugated equine estrogens. And we haven't studied estradiol, especially through the skin, as well for cardiovascular protection. I don't believe it's harmful, but I think we have a ways to go in terms of studying how we actually use hormones now to be able to say to women, this will protect your heart. We believe it does because of some of that earlier data, but we haven't actually done these studies, which I think is going to be a theme in everything I tell you tonight, which is we haven't done enough studies. Like, we need to thoroughly understand how we're prescribing now and what the impacts of that are before we tell women, oh, it does this, it does this, it does this. You know, we think it does this, but we haven't actually genuinely looked. And these studies are really hard to do. They take a long time. You need to be on it for a very long time. So a lot of talk was about dementia in the movie. And if you actually look at the studies we have, and there are many of them, for women who go through premature ovarian failure, premature menopause before the age of 45, starting estrogen at that time and continuing it at least to the natural age of menopause around 52, reduces the risk of dementia. In no other group has it ever been shown to reduce the risk of dementia. There are a lot of reasons for that. There are a lot of reasons around how it's been studied. There's a lot of reasons around the complications of determining what's Alzheimer's and what's vascular dementia, but we don't have data that tells us that it's protective. Probably, and what Dr. Mosconi is referring to is probably if you started at your transition and continue it until you're 85, you might be reducing your risk of dementia somewhat, but very few people actually do that. So how do you make an informed decision? You have this conversation with a doctor who knows what they're talking about, and they look at your medical history, your family history. You know, how do we balance all of these possible risks and benefits? The big risk we always talk about is breast cancer, but in reality, estrogen doesn't increase your risk of breast cancer. In fact, conjugated equine estrogens in the WHI lowered the risk of breast cancer by about 22%, which nobody ever tells you, and that was a statistically significant result. Progestins or progesterones, which are important to prevent uterine lining cancer, very slightly increase the risk of breast cancer when used for over 5 years by one additional case of breast cancer in 1,000 woman years, which is a very small increase. It is probably a lower increase than the impact of drinking a glass of wine a night or eating red meat. But it's there, it's detectable, we can see it. And we can see it because 1 in 8 women get breast cancer. And so if you increase that rate at all, you're going to pick it up. It's not an uncommon event. Do I think the progestins cause breast cancer? No. Most of the breast cancers in the Women's Health Initiative happened in the first 2 years. And we know it takes probably 9 years on average for cells to transition into a cancerous state. So most likely what it was happening is it was promoting cells that were already transitioned. But we have to think about all those things and have that conversation. And that's how you make an informed decision about whether this is right for you.
So what happens if you want HRT and your doctor doesn't want to give it to you? Or
You
says,
need a new doctor, or you need to listen to why they're saying no. So as I tell my patients, I'm a huge proponent of hormone therapy. Love the stuff. Give it out every single day. And there are still times when I say, this is not a good choice for you, and I'm not comfortable prescribing it. Because what I'm doing in my head every time I have that conversation with a woman is, what are the risks, what are the benefits, and how do those two weigh out? And when the risks are higher than the benefits, I don't tell them that it's a good idea. I tell them why it's not a good idea, because they deserve that information. But not everybody is a good candidate. I'll give you a personal example. I am a breast cancer survivor. I cannot take hormone therapy. I would love to take hormone therapy. Trust me. Every time I have a hot flash, I think about estrogen. But I can't because that would not be the safest choice for me. So I use other medications.
Understood. Thank you for sharing that.
Mhm.
Dr. Uloko, thank you for being a part of this panel. I'm so glad you can join us tonight. So I have a question for you. The field discusses the lack of solutions for sexual wellness during menopause. Why do you think this aspect of women's health is often overlooked, and what can be done to change that?
This is also a fantastic question. And I think it speaks a lot to culture and society, right? So I'm a urologist. I actually take care of all genders, so I get to actually deliberately see the differences in how your genitalia determines your health care. And in men's health, and urologists traditionally take care of men and men's sexual health, and it's just deeply ingrained in our practice. And so it's almost like a birthright. Of course, you should feel good and have your quality of life match that. And part of feeling good is your sexual health. And we have even said, sexual health is one of the markers, the pivotal markers of health, right? The notion of erectile dysfunction is linked to heart disease. And so we are even tying your sexual health to your overall health. And in women, it's not even remotely that. And so, and it goes back to the cultural norms of female sexuality. It's been something that's been, shamed and secretive, and that although we want to believe that science and culture and medicine don't interact, they actually very much are intertwined. And so, due to that, there is a significant lack of training for physicians around female sexual health. I mean, the statistic is that if you're going to go to medical school, only 50% of medical schools even require sexual health training. And if you're going to get it, it's going to be 80% skewed towards men. And we actually just did a research survey asking, as a chronic pain specialist and a patient advocate, I oftentimes am sitting with patients and hearing quite, horrendous stories of lack of access to care or dismissal or refusal of care. And, so I wanted to do a study, and this is a study that's just adding to the body of literature that already shows that doctors are not well informed on women's sexual health or even taking a sexual health history in a woman. And then how do they know how to diagnose and then how to treat? And we found that 75%, this is a preliminary research, that 75% of medical trainees from across the board, whether that's urologists, gynecologists, primary care providers, ER, um, your primary, your PCP, those people, 75% had never heard about the vulva. You know, they didn't know how to examine it, the physiology, these disorders, and then also how to treat. So we have, unfortunately, a large workforce that just doesn't know much about women's bodies. I mean, traditionally, gynecology um, has been historically focused primarily on pregnancy and cancers. And so, but that's a very small part of a person's life and a woman's lifespan. And so we need significant education reform across all sectors, from starting from the medical school, moving up to formal training, even in our current practicing physicians.
Absolutely. So, Dr. Loco, what are some of the sexual health changes that can come with menopause? I think the movie touched on it, but I don't think it really went into deep detail. Can we kind of spiral into
Yeah.
that a little bit?
Yes, yes, yes. So I love this work. I love this work because I'm going to use an analogy and it's going to sound so corny, but I promise you guys that there's a reason why. So your vulva is a garden. And the way that you keep your garden healthy and getting cucumbers every season is by hormones, right? So your garden oftentimes needs sunlight and water and nutrients and all the things. And for the vulva, that is the hormones. And the hormones that we think about oftentimes are estrogen and then progesterone. But actually, the vulva is actually a very testosterone driven organ. So my research team defined how many nerves are in the human clitoris, and we're currently mapping out the rest of the vulva now. But it's a significantly testosterone-driven organ, and when we lose those hormones, which starts happening and declining, testosterone starts declining in your 20s, and then you have a steep drop in estrogen and progesterone right around perimenopause and then the menopause transition. So now your garden has lost its sunlight and nutrients and water. And so what then happens is that the vulva, the skin and the tissue of the vulva starts to change. So your skin is thinning, it's red, raw, and inflamed. Your labia start to disappear, your clitoris starts to shrink, your vulva literally starts to shrink and change. And these changes were previously called vaginal atrophy. We now have the term genital urinary syndrome of menopause. All of those changes result in symptoms that can look like pain with sex, recurrent urinary tract infections, overactive bladder symptoms. These changes can also lead to pelvic organ prolapse and incontinence or leaking of urine. It can also lead to conditions called like recurrent vaginal infection. So ultimately, I think of those symptoms now as a vulvar specialist and hormone specialist, as these are actually symptoms of an unhealthy garden. But the beauty with gardens is that as soon as you give it sunlight, nutrients, and water, aka low dose vaginal hormones, that garden will spring back to life. It is one of the coolest things as a researcher. I strongly think there's regenerative properties in the vulva that we have just not explored, because I've never seen that happen on male anatomy, but I see it all the time in vulvar anatomy, right? This garden that is not health happy comes right back to life, and it's just one of the coolest, most fascinating things.
Also, Dr. Loco, the film touches on disparities faced by Black and Latino women in menopause treatment. And how do these disparities manifest? And what steps can be taken to ensure more equitable care?
Yeah, so I think if we think about big systems, right, we have to think about the fact that a lot of women's health is disparity care because of the fact that most medical trainees are leaving training without learning about women's bodies. So if you just even think about 50% of the population isn't getting the care that they deserve, isn't getting the care that they need. And then when we start thinking about systems and how systems affect people and how the intersections affect people, so whether that's your race, your socioeconomic status, your religion, your culture, all of these things start to really build upon a system that's already unequal. And so for Black and Brown women, they tend to have much higher, much longer rates or much longer time in menopause and much more severe symptoms. And the disparities is that, a lot of people, like if Oprah Winfrey can't get the right menopause care, what's going to happen to the people that don't have the access, that don't have the luxury, and don't have that privilege? They're going to get these effects much more. Oftentimes, and I think it's cited in the documentary, that they're not even asked about their symptoms. They're not even talked to. And if they are talked to about their symptoms, there's kind of there's a very permissive um, attitude in healthcare of it's okay for women to suffer, which is not the same attitude in men's health. Like we pride ourselves in like making sure every man has testosterone. You can't watch a baseball game without learning about testosterone, and everyone should be on testosterone. And that's not the same conversations that are oftentimes happening in women's health. And so if you're not even getting talked to by your doctor about this, you're not even getting the education and the resources that you need to be able to make informed decisions about your own body. And then factor in that a lot of the insurance-based models around menopause care do not cover a lot of the medications, or they cover medications that are just blatantly wrong and dangerous for patients. I mean, the system is just from top to bottom needs an overhaul.
So here's a question for either of you. So the U.S. healthcare system is often criticized for not adequately preparing medical students and physicians to treat menopause symptoms. So what specific training or policy changes are needed to improve menopause healthcare?
Ugh, that is a huge question. So I'm an OBGYN. You'd think that in OBGYN we would be trained in menopause medicine. I mean, you would hope that in medical school we would talk about menopause. It is 50% of the population for 40 to 50% of their lives. Why do we not talk about this? I don't know. But okay, so you go into OBGYN, the care of women. We should be taught this, but we're not. And some of it is historical. OBGYN was founded not by women. And what men can see from the outside is women have periods, have babies, have tumors, and that's what we need to take care of. Women above the age of 50 have been disposable, invisible for generations. So we have not researched women's health in that age range. We have not taught women's health in that age range. And, if you look at studies, 20% of OBGYN residents get formal training in menopause. That's ridiculous. Even lower numbers of primary care physicians get training in menopause. And I'm not even going to go into surgical subspecialties. I'm sure you can tell us.
I got you. Yeah.
Menopause training within urology, because I'm married to a surgeon. I know he knew nothing about it. It's We don't value women in this age range. We don't see these women as productive or useful. So why do we even think about them? I mean, just understanding women's cardiology above the age of 50 has taken us generations. And the fact that women are not small men, we are different, and we need to be studied separately and thoughtfully. Many of us are advocating for increased training, but it takes a sea change, and it takes like the will to actually see this as an important area.
Yeah, it's 100% agree. I am a weird beast where I started medical school at 17. And so I've been in healthcare like from day one, studying patients. And now I've been in healthcare now for almost 15 years. Woo. And it wasn't until my fellowship, and it's the only fellowship in the country for women's sexual health from a urology standpoint. We learn about men, women, everything. Anyone with genitals, you'll learn about their sexual health at this fellowship, and one of seven. And that number sounds really cool and impressive, but actually to me, it's like only seven people have done this, right? And we need an entire workforce to do this. And so when I actually built one of the first clinics run by a urologist, that vulvar sexual health clinic that took insurance, because I wanted to say like we can do this within an insurance model. As urologists, we also have a responsibility for menopause, and I think that's the interesting thing, is that menopause has been siloed only to women's health, even though menopause affects every single system in the body. And so, and again, I'm bringing this Oprah thing of Oprah was having chest pain and, oh, sorry, she was having heart palpitations. I mean, I would not want to be Oprah's cardiologist. That feels like a lot of pressure. And her heart cardiologist was like, they didn't know what to do, and it was actually menopause, and so that's what, like, that's the top cardiologists, and they weren't even trained on menopause. And so this is the work that I do. I actually left my academic position to build a health tech company, that specializes in mass training of clinicians. So I'm a big believer that technology is where we're going to have to go, to fill in the gaps where healthcare is training. How do you train? How do you mass train an entire workforce that just did not get this education? We can't send them all to conferences. That means no one's at work. So we have to start delivering um, high level education, directly to them. And that is the company that we're building at Vulva AI, to help doctors learn this in mass.
I think you brought up a really important point, which is you do it within the insurance system. And, there are phenomenal experts in the movie, but several of those people don't take insurance and they charge $1,500 to $2,500 a consult. And while they may be incredibly expert, for most women, that is completely inaccessible. And so I agree, like this can be done within the insurance system. However, we have to face the fact that insurance compensates poorly for the care of women. They compensate. There's a wonderful study done by a GYN oncologist that looked at the same procedure on a man and a woman from a genital perspective. So a urethra surgery, a testicle surgery, an ovary surgery. And, keeping in mind that the ovaries are inside the body, not outside the body. And in general, the procedure on a man was compensated 3 to 10 times better than that on a woman. And those rates have gone down since OBGYN became a primarily female specialty. So it makes it even harder for women to get good care because doctors don't have time to give good care because they're just trying to make their salary every day, especially when caring for women. And so much like you're working on educating through your company at Genève, what we do is we run a series called Menopause 201. It's free webinars for healthcare professionals of any kind, and we talk about advanced topics in menopause for an hour every month.
I think something that you talked about is that pay inequality. I literally lived it. When I opened, I had a men's health clinic and a women's health clinic, a vulvar and penile health clinic. And it was shocking. I was like, wait a second, this vulvar surgery was way more complex to
Mm-hmm.
do, and this penis surgery was way easier. And I'm getting compensated so much more. And I'm like, and these inequalities are things that most doctors are not aware of.
Yeah.
And most chairmen, most of the things, because doctors are also incentivized of like how much, so especially surgeons are like, how many RVUs are coming in? How many, like, da 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 da. And so oftentimes, if you look, women tend to go into specialties where they're taking care of women, even in urology. So a lot of the urogynecologists are women, and they get poorly compensated in comparison to like a prosthetic surgeon, which I am, but I'm also then a vulvar specialist. And I was like, I am literally living this inequality. And I was like, this is wild. So really also being very, addressing the pay inequality is going to be such a huge issue, because if you're trying to meet your overhead, you're going to want to be doing obstetric work, right? You're going to want to be doing higher surgical returns because you left school with a lot of debt. And so in order to pay off that debt, you're going to need to be doing, procedures or selecting patients or selecting disease states that are going to reimburse highly. And menopause and vulvar health don't do that. And so that's why a lot of doctors also, there's a financial incentive to not learn about this, of like, why would I learn? Like, I'll send that patient somewhere else. But turns out people have just been kicking the can down the road. They have to, and those poor patients, which is again 50% of the population outside of pregnancy and cancer, don't have anywhere to go. And so these movies, these conversations are so important because even in healthcare, we are ignorant to how these disparities are like happening right in front of our faces.
Absolutely. Well, to that point, is there space for healthcare providers to play a role to help women through this transition?
Yes.
Yeah.
Yeah, yes, on so many levels. I will, I'm gonna say a fun little anecdote. So it all, and I think this documentary is a really fun thing for me because this it's one CME, which for doctors they need CME to stay on their certification. So it's a great incentive for them to watch. And then to get aware of, wow, we are doing this to 50% of the population, because I actually think that once doctors can be really powerful advocates. So in the urology world, when Viagra came out, ooh, let me tell you all the fun little tricks that they did to get this medication covered. So when the first came out, it was really expensive. So many people wanted it, but they couldn't get it. And so same kind of thing like HRT is really can be expensive, and there's a really poor insurance coverage for the right type of HRT for a lot of people. And so, or the safest HRT for a lot of people. And so a lot of urologists saw that and they were like, whoa, this is wild. So then what they did is that they then linked erectile dysfunction, which has been significant, which was seen as just sexual health, which is a frivolous thing. They linked that to disease and they linked that to heart disease. And they went to Congress and they said, hey, erectile dysfunction is actually a marker of health, and this should be reimbursed better, and all of these things, and we should create access, and we should create cheaper data, like all of coverage. We should create better coverage for this. That was actually physician driven advocacy, and that is what I aspire to do in the world of menopause. And then there's so many physician advocates. I mean, Dr. Dunsmore Sue is literally like left and is doing that work on the corporate level. And this is kind of a really fun thing of where corporations are kind of going to be a huge factor. There's going to be a huge swell, and it's going to take patients speaking up. It's going to take doctors speaking up. It's going to take industries understanding why this affects their bottom line to create legislative change.
Yeah, I think that's a great example with Viagra. I will say though that we in the menopause space and the gynecology space have been advocating for hot flashes being a marker of cardiovascular health. We know this. Bone health. And we know all of the beneficial things that estrogen and progesterone do. We have taken those to the FDA. We have done all these things, like something as simple as vaginal estrogen. We love vaginal estrogen, right? Great stuff. Safe for most women to use, even with some of the risk factors that might prevent systemic estrogen. Huge black box warning on that vaginal estrogen that says this is going to cause heart attack and stroke. This is blatantly false. It does not do that. But the FDA requires that they label any product with estrogen with that big thing. And I spend, an hour a day explaining to women I've given them vaginal estrogen. And I've said, don't read the insert. And then they read the insert. And then they come back and they're like, oh my God, you're trying to kill me. And, we can't even get that black box taken off, much less get these things covered. Women's health is just one of those areas where we have struggled for generations to get adequate coverage. And I wish I had the answers. I will continue to scream it from the rooftops. But I do agree with you that corporations may be one of the things that actually pushes us over the edge. Because when they're bringing in menopause benefits, they want to celebrate it. And then all their employees come back and say, well, hey, you gave me this menopause benefit, but our insurance doesn't cover any of the medications that my doctor is now recommending. Then maybe we'll finally have a voice that gets listened to.
Thank you for that. No, it's insightful, and you're right on point with that. And there's a lot we can do as advocates for women's health, particularly during menopause and postmenopause.
Mm-hmm.
And I will say there is One of the I saw comments, and something that I truly believe is the power of patient voices. And patients are so powerful. They don't know how powerful they really are. And I think one of the really fun things of seeing this patient advocacy happen and how it actually created change on a level, granted we still need places to go, is the conversation around pain control and IUD placement. And this is I mean, if you've ever heard of the, as someone that performs vasectomies, and then hearing the experience of people having an IUD, which are both contraception procedures, it is night and day. It's almost like a spa day when you get a vasectomy. Like there's music and there's like mood lighting, a nurse is holding your hand. I'm making sure that you don't feel anything. We're having conversations. It's such a lovely experience. People fall asleep during vasectomies. And then when I started taking care of women and pelvic and vulvas, and then a part of my work is understanding what contraception they're using, and I would just listen to their stories of like, oh, I'm scared to get an IUD, or when I got my IUD I passed out on the drive home, or I vomited, and I was like, what? One of the most fascinating things is I love listening to my patients and hearing their stories, because that actually made me an advocate. It made me of like, wait, no. And that those voices, it collectively actually took on a life of its own on social media. And there was a huge swell over the summer of women sharing their stories. And that collective voice actually then, encouraged the CDC to start putting out guidelines around pain control. And that is something that I could tear up at that.
Yeah.
That is the power of collective organization. That is the power of saying, my body, my choice, and I deserve I truly just think it's the bare minimum rights of like
Absolutely.
the agreement that I'm going into healthcare system. I should be comfortable if I can. That's the bare minimum. And I'm so excited for us getting more than the bare minimum.
Yeah, I think I'm really hopeful as a gynecologist that the CDC recommendations will help us as we advocate for our patients to get covered to get pain medicine for an IUD. Because that's the other little dirty secret is no insurance company will pay for you to have any pain medicine. They don't cover the medicine, they don't cover the procedure to give it to you. We talk a lot in OBGYN about nitrous oxide. Great method for pain relief during a procedure like that. Can't get it covered because pain relief is part of the procedure for the insurance companies. But also, there's this whole history of women needing to suffer through anything that has to do with a
Hmm.
reproductive life.
Well, I want to have some time to take some questions from our audience. And if we can begin to do that process, we have Bria Fitz on to help facilitate that. So maybe we could take the next 15 minutes.
Yeah,
Okay.
definitely. I saw that you were in the chat, and you were replying to Nicole's comment about hormone level testing.
Yeah.
So yeah, could you please expand on like how you don't see testing as useful?
I love talking about testing because I think in so many other disease states, we do a lot of testing and we titrate things to levels. And so it makes sense at some level. It feels like it would make sense to do that in hormone therapy, but it doesn't work the same way. So the reason hormone testing is not as helpful for perimenopause or menopause is that our hormone levels during our reproductive years, during any given cycle, someone said they can be as high as 500, but they can be as low as 12. And all of those are normal. And they change throughout the month over the course of a normal cycle. And at all of those levels, most women have no menopausal symptoms, right? And they're protecting their bones and they're protecting their hearts and all the things that hormones do. So when you have a normal range of 12 to 500, as I tell women, I can't tell you where in that range you're going to feel better. I know that any level of HRT that I give you is going to protect your bones. It may protect your heart. And then I'm going to titrate that hormone to where you feel good and feel like yourself. I have a range of safe doses that I can use, and I need to listen to you and your symptoms to tell me when I've reached the right dose for you, because every woman is different in terms of how she feels at a different level. And everyone processes it differently. And there are all sorts of other factors like that. We don't test progesterone because progesterone, when we're using it in HRT, and we can argue about some of its side effects that are beneficial, but progesterone is really there to protect the uterine lining from growing under the influence of estrogen. Estrogen's like a fertilizer for the uterine lining, and progesterone's like the lawnmower. It says, nope, not going to grow, not going to grow into a cancer over time. If we give you straight estrogen, we can do that. So testing progesterone doesn't really tell us anything. We sort of know the right doses to balance with the estrogens that we're giving. And again, some women process this differently, and sometimes we have to adjust it if someone has bleeding. But in general, we know how to titrate that. The third one I want to talk about is testosterone testing, because I think there are a lot of myths around testosterone. And I want to be very clear. I love testosterone for hypoactive sexual desire disorder in women when they've done the hard work of all the receptive desire, understanding and changing pain, making sure they have no vulvar pain and no sexual pain and all those things. Testosterone, as Dr. Loco said, starts to decrease in your 20s. That's true for men and women. It sort of goes on a slow downslope throughout our lives. It drops precipitously in our 80s, but it doesn't drop at menopause. And I think a lot of people believe that as your estrogen and progesterone go down, your testosterone also goes down. It doesn't actually. It's on a slow downward trend, but it doesn't dip at that point. When people get testosterone testing, most often they're sent a free and total testosterone test to the lab. That test is valid at male levels. It is not a validated test for female testosterone. So you can get ranges all over the place. You can do the same test 2 days in a row and get completely different values on that test. It's not a good test. There is a test as a liquid chromatography test that you can send to sense that. But again, not necessarily needed. If someone is struggling with libido and we want to use testosterone for it, we can use it at a safe female dose level to help with libido, because we're using it for a side effect, which is it makes you feel slightly more horny sometimes. We don't have any data for testosterone for muscle and for energy and for brain health. We should study it. We should look at how testosterone behaves in the female body after menopause, but we never have. And we haven't looked at what's the safe range. Where do we dose it? All of these things, women deserve to have good data guiding their care. Not just, hey, I've given this to like 50 women and they feel great. As I like to say, and this is a bit facetious, but I'm going to say it anyway. If I give 50 women cocaine, they're going to feel great too. So that's not acceptable medical evidence. Medical evidence is trials, and we need to do those trials. And I will advocate every day for those trials, but we need to do the trials before we just widely offer this to everybody as the next most beneficial thing.
There was a follow-up question from Nicole as well, and I think you kind of touched on it. She asked, how do doctors know how much to prescribe if we're not doing hormone level testing? So what I'm hearing from you is kind of you start somewhere and then it's a trial and error.
I don't like to call it trial and error. I like to call it try and try again. Sounds
Okay.
We typically start for a menopausal woman in the middle range. So if I'm using a patch, a 0.05 patch, that resolves symptoms for most women. It's adequate to support her bone and cardiovascular health. If it works for cardiovascular health, like I said, that's a little bit questionable. And most women do great on that amount. Some women need more. Some women don't like the way they feel on that, and we go down. I typically don't go lower than that, because the lower doses I typically use in my 70 and 80-year-olds who want to stay on hormones, but we want to start reducing clot risk. So we slowly titrate down a little bit lower. But in general, we sort of start in the mid-range and then we adjust as needed.
And then I just have a slightly different approach solely because I'm a urologist. And the way that we train is just very different when it comes to hormones. Our philosophy is that hormones are safe when done safely. And so we actually have really solid guidelines for hormone replacement therapy. And then it's just called testosterone replacement therapy, but it is HRT. And the way that we do it is we start at a low dose, we recheck, and then we assess your labs. So really when we're checking, all we're asking is, are we safe and are we effective? And then we assess whether or not we're safe and effective, because we have ranges of like, okay, this is unsafe, this is ineffective, and where are you? And so that's what my approach to women's health and women and menopause and HRT. So I actually do check labs, not necessarily for one, I'm also a researcher, so I like checking these numbers and getting, because before we get to the clinical trials, we first need to do case series, right? Like until we get to the clinical trials, we have to start collecting some data. And so I love collecting that data and kind of thinking about it from a data-driven point, but still the same ethos of, are you safe? Is this effective? And it's really mostly based off of your symptoms. And so really the symptoms are the biggest thing driving where we're going. I just like it because that's just how my brain works. And it's like, and some women love the idea of like, okay, I was at 50 and I know that when I'm at 50, that's where I feel good. And I'm like, but it's going to change at some point, because your body changes and needs different things. So, I tell them, don't get attached to a number. It's more so, your biggest thing is how do you feel? And then these numbers help guide our clinical decision making, and also they help us make sure that we're safe. Because one anecdote that is, I had a woman who was very young and had a very traumatic birth and had to then have a surgical hysterectomy. And so they took everything, but then their doctors were awesome and then immediately put her on estrogen. The thing is, she came to see me after 3 years and was like, I feel terrible. And I was like, well, you have a young kid, and also you're still dealing with the birth trauma, because I think that's also something that we don't talk about, is the lasting effects of birth trauma on people. And I was like, okay, so what are your goals? We went through her goals, and I said, has anyone ever checked your labs? Just curious. And she said no. And so when we checked her labs, her estrogen was at 600, and she was taking a very small dose. And so it's just one of those things as to why that's just the way I was trained, and I just take that training into my HRT. It's just in case you miss something, right? And women, one of the things I always encourage my patients is to know your body, trust your body, because I think something that was said is that women are oftentimes told not to trust their body. Your body, my choice is the name of the game of medicine, unfortunately. And so it took that woman advocating and saying, no, there's something wrong. And all the doctors were like, no, you're already on HRT. And then she came to see me. And that's where I do see the value of checking, but it's not everyone. And we don't have set guidelines, but this is where we get to create it. And I think this is the fun part of research, is that, if I were doing prostate cancer research, it would take me 40 years to make any sort of gains in that. But because women's health research is still so nascent, just even small studies it's adding to that foundation of the body of work, which will ultimately lead to the clinical trials and lead to better clinical trial data.
I think you made a really good point, and I should have been more clear. We do check labs if something's not going well. So if I have somebody on, say, the highest patch dose and they're still not feeling great, I check labs. Maybe they're not absorbing it. Maybe they're getting too much. All of those things are really important. So there are times when it makes sense to check labs, or there are a few other times that we might check them. You said we don't have guidelines. The only guideline we have is the Menopause Society.
Thank you both for your perspective on those questions. Dr. Uloko, you kind of talked about IUD placement, right, and how patient-led advocacy has led to some shifts in that area. Can you expand a bit on how patients can better advocate for themselves about menopause care when they're with their doctor?
Yeah, okay. So one thing I want people to know, you don't have to suffer. Oh my God. That's just like suffering is not your birthright. Like pleasure is your birthright. I just need everyone to know that, because it's such a fascinating conversation. Again, because I'm working with, the different genders, and I get to, when I talk about quality of life conversations with men, there's never like, oh, I don't know. It's okay. It's always like, yeah, no, of course I want to feel better. Versus when I talk about quality of life conversations with women, it's like, well, it's not that bad. I'm like, oh my God, you told me you're not sleeping. You're gaining weight. You're anxious. You're depressed. You're all these things, and you're getting UTIs all the time, but it's not that bad. It's like, women have been socially conditioned to just accept suffering. And then the healthcare system then encourages it and continues that encouragement of like, well, you don't really need hormones. Like, is it really that bad? You know, no, I'm not here to suffer. Like, this life is hard enough. I want to feel my best. And so I always want to give people permission that they don't have to suffer. They're like, when should I go in? I'm like, whenever you're bothered, whenever it's affecting your life, whenever it's affecting your sleep, whenever it's affecting you, because you oftentimes are the center of your household. You're contributing to society in such significant ways. Like, this isn't just a feeling. There is data about how women contribute to society. And I was like, how much more could we be contributing if we weren't sweating or if we weren't having like migraines because of menopause? Like, how much more if we weren't suffering? And so that is what I like to tell people is that, oh, you don't have to suffer. As soon as you are bothered, come on in. Let's have this conversation.
I love that answer. You know, I tell all my patients, nobody's waiting at the end of menopause, the menopause finish line with a blue ribbon for you.
Yeah.
You didn't take a hormone. We have been like, we see it in the childbirth industry, we see it in the menopause industry. Women are told they're supposed to suffer, it's natural, you need to do only the natural things. But naturally, women used to die in childbirth. And naturally, most of us didn't survive to even get to menopause. So I'm not sure what natural we're aiming for. If I'm going to live to be 90, I want to feel my best until I'm 90. I don't want to spend 40 years suffering. Like, that doesn't sound fun. And, you know, like you said, men have no qualm about the quality of life thing. Like, how many men come into your office and you say, hey, you have erectile dysfunction, here's some Viagra, and they're like, oh no, you know, it's natural, it's okay, I'm just gonna suffer through it. I doubt you've ever heard that once. And that, you know, I want to make it clear, I'm not taking away women's agency. Like, if you want to go through menopause in a natural way, that's fine. That's your choice, but you should have a full understanding of all your options and what they can do for you. So you're making a choice, not being told that you're supposed to suffer.
Yes, informed consent is one of my favorite things, is laying out the options, because this is what
Mhm.
we do in urology. We lay out the options and you make the best decision for yourself. I don't live in your body. I don't know your life. I am just here to guide you to the decision and share all the information that I have. And then you make the decision for yourself. And I think that's something that we have to start encouraging our medical doctors as we're training them. Like, we got to let women make choices for themselves. We got to get rid of this paternalism that happens in medicine, especially when it comes to women, that your body, your choice, you get to make that. And that's a really strong sentence in the current political climate, but I really do believe if you give women the choice, they will always make the right one for themselves, like
Correct.
everyone.
Yeah, no, absolutely, absolutely true. And, you know, I think that there, my job as a doctor is to be the keeper of this information. I have spent 12 years learning this information in all its intricacies. Let me share it with you.
I'm loving this conversation. I believe we have time for one more question. So, for both of you, in the documentary, they lightly touched on how dental hygiene overlaps with menopause. Can either of you talk a little bit more about like the dental health impact of menopause and why women lose teeth?
I wish we had more research on it. Can I just start there? I think we would both agree. This is an area that we have not adequately researched. As Dr. Mosconi says, and as I like to say, we have estrogen receptors from the top of our heads to the tips of our toes. And when your estrogen goes down, it goes down everywhere. We get heart disease, we get bone disease. These are bones that are holding your teeth. So as these bones change, the way your teeth are held has changed. But we also have estrogen receptors in our mouths and our gums that create blood flow, that create that stimulate our salivary glands. So as those things change, the tissues around that are holding the teeth in also change. But remember, much like the vulva and the vagina, as your estrogen levels change, the bacteria that live there change. We know our gut flora change, our vaginal flora change. There's no reason to suspect our mouth flora don't change as well. And that's going to impact dental health. All of these things are going on, but I don't think we have all the answers in this area.
Thank you. Denise, do you want to close this out?
I will close us out. First of all, thank you both for just this insight, this education, helping to raise awareness around the menopause and all the issues that go with that, and just, empowering women to take agency to have these discussions with their physicians. We have to be able to do that and do that freely. So thank you for all that you do. And I hope to see you on the circuit soon somewhere. And thank you to our audience for coming and listening and forwarding great questions. I think this is building conversation all around.
I put some things in the chat to look for more information. I put the Menopause Society website, menopause.org. They have great patient information. I put our website, genev.com, which has free information. Obviously, love to hear more about vulvi.
And with that, thank you, Dr. Dunsmore Sue, Dr. Loco. Everyone, have a great weekend.